Did I do? It was there.
Maman, on the help cheyavo, Maman.
Ma'am, what happened?
മാമൻ അതെ എനിക്ക് ചെറിയ സ്ക്രീനായിട്ട് മാത്രമേ ഇപ്പൊ കാണുന്നുള്ളൂ. ഒരു ഒന്നും കൂടെ മിനിമൈസ്.
മാം അതിന്റെ റൈറ്റ് സൈഡിലായിട്ട് ആ സ്ക്രീനിന്റെ ഒന്ന് അതിന്റെ അകത്തേക്ക് ഒന്ന് കേഴ്സർ കൊണ്ടുപോയി വെച്ച് കഴിഞ്ഞിട്ടുണ്ടെങ്കിൽ അതിന്റെ അകത്ത് ഒരു ആരോ മേളിലോട്ട് കാണിച്ചിട്ടൊരു ബോക്സ് ഉണ്ടാവും. അതിന്റെ അകത്ത് ക്ലിക്ക് ചെയ്ത് വെച്ചാൽ മതി, വലുതായി വന്നു.
കണ്ട അത് കുറച്ച് സൂം ചെയ്യാൻ പറ്റുന്നില്ല. ചെറിയ വിൻഡോ
അതിന്റെ മുകളിൽ ഒന്ന് ക്ലിക്ക് ചെയ്താൽ മതി.
നോക്കട്ടെ. ശരിയായി. താങ്ക് യു.
So we are live now. I am admitting all the people.
Yeah, can I start?
Yes, sir.
Good evening, everybody. Welcome to this national webinar at Believers Church Medical College and Hospital. Today, we have a special topic, autism spectrum and beyond. And to throw light on this topic, we have the Professor of Developmental Pediatrics and DBT Wellcome Trust India Alliance Clinical and Public Health Intermediate Fellow, Dr. Beena Koshi from CMC Vellore. She's also the member of the Institutional Finance Advisory Board, CMC Vellore. After completing her MBBS from the prestigious Christian Medical College Vellore, she went on to complete her MD Pediatrics from Kasturba Medical College in Manipal and did her postdoctoral fellowship in developmental pediatrics from Christian Medical College Vellore. She completed her autism fellowship in UK, awarded by the Newcastle University, Newcastle upon Tyne, UK, and was awarded MD Clinical Research in Pediatric Neurodisability. She has 7 ongoing projects, 10 completed projects, and close to 50 national and international publications in peer-reviewed journals. She is the invited advisor and panel member for curriculum development for children with ASD in Tamil Nadu. She has done so many invited lectures, and she has contributed chapters in Hutchinson's pediatrics textbook and also the Hutchinson's Atlas of Pediatric Physical Diagnosis. She is member of many prestigious associations like the General Medical Council UK, European Academy of Childhood Disability, Association for Research in Infant and Child Development, and International Society for Autism Research. With a clinical experience of over 18 years in pediatrics and 15 years in pediatric neurodisability, ma'am is a doyen in the making. With clinical research experience in both India and UK, it's a great privilege to have her for this talk. Beena ma'am, welcome to this webinar. And to moderate this session, we have none other than recipient of the E.G. Suresh Memorial Award for the Best Pediatrician in Kerala and the Satyadas Memorial Oration Award by Kerala Medical College Teachers Association, Dr. Girija Mohan, Senior Professor of Pediatrics at Believers Church Medical College Hospital. She's the Professor and HOD of Pediatrics at Believers Hospital, and she retired as Professor and HOD of Government Medical College, Alleppey. Dear ma'am, it's a great privilege to have you with us to moderate this session. Over to Dr. Girija ma'am to give an overview and hand over the session to Dr. Beena Koshi. Thank you, ma'am.
Good evening to each one of you. Thank you, Dr. Jacob, for your kind words. And at the same time, I am thanking you for inviting me to as a moderator for this session on an important, relevant topic, autistic spectrum, and that too by an expert or doyen in the authority in the field of developmental pediatrics. And at the same time, I am appreciating this opportunity to appreciate and acknowledge all your sincere efforts to conduct this webinar in a very effective way. Congratulations, Dr. Jacob. Then coming to the topic, you have selected the expert person for this relevant topic, autistic spectrum disorders. So the common is one of the important neurodevelopmental disorders, and it is for the sake of students. It affects the communication, verbal and non-verbal, social communication, and I think you will be hearing from the expert. And it is very important. You must know the basic things about ASD, because early diagnosis and early intervention are the mainstays of treatment management of autistic disorders. And another point which I have to add at this context is, whenever a child is, it is for the general practitioners as well as for the peer, whenever you have a contact with the child, you must always assess the social as well as language developed. Do not forget about these points whenever you have a contact with a child. With that, you can sometimes make even a baby who has not attained social smile, delayed social smile may be a pointer to autistic spectrum disorder. And it is called a spectrum because it can be there from mild, which may go unnoticed, to very severe, unmanageable child. Anyway, I'm not going to the details. Let us listen to the expert. And another thing is, you have to, if you can clear all your doubts and queries, please put it in your chat box. And so let us listen to the expert. So it's over to you, Dr. Beena Koshi. Thank you.
Okay. Thank you, Dr. Girija, Madam, and thank you, Dr. Jacob, for inviting me and for those kind words. I will now start sharing the screen. So what I thought is not just about diagnosis or management. That this webinar is looking at diagnosis, management, as well as what we can do beyond what we routinely do in our clinics for individuals with autism spectrum disorder. So my overview of this talk will be looking at diagnosis. We will look briefly on update on autism. I really love talking about autism because a lot of misnomers and misinterpretation and misrepresentation is there about autism. So I can talk for even days on autism. So, but I will just condense it as much as possible for the audience today, and I'm happy to take questions later on. Today, I'll be mainly looking at theoretical models. If I may say, autism research field actually is exploding with different theoretical models, different interventions models. We just briefly look at some of them and look at what can be a pediatrician's or a general practitioner's or a student's approach to these conditions that will include diagnosis, assessment, and intervention. So we've just started with the pioneers of autism, Dr. Leo Kanner and Dr. Hans Asperger. Professor Kanner was Austrian by birth, but he moved to Germany, then to America. And he is the first person to write about autism. Professor Hans Asperger, again, was Austrian born. He was an Austrian scientist, and he actually presented about Asperger and similar conditions, or similar to autism, as early as late 30s, but wrote about it in 1944. So these two individuals are considered as the pioneers of autism. And some of what they have written actually really rings true even today. So this is like Professor Kanner has written in his original publication. I was struck by the uniqueness of the peculiarities which Donald exhibited. Donald is a child he examined. He could, since the age of 2.5 years, tell the names of all presidents and vice presidents, recite the letters of the alphabet forwards and backwards, and flawlessly, with good enunciation, rattle off the 23rd sound. Yet, he was unable to carry on an ordinary conversation. We see children like these even today, excellent in learning, rote learning, visual learning, but actually struggle in social communication. So what is actually about autism? There has been diagnostic and statistical manual has brought out diagnostic criteria every year. DSM-5 has come out in 2013. So compared to the triad that is originally described as deficits in social interaction, deficit in social communication, and repetitive behavior, the DSM-5 now makes it into two main categories. It is impairment in social communication and interaction, and restricted and repetitive patterns of behavior. So we will just briefly look at some of these features. What are the other criteria that we need to see in this diagnosis? Is it has to be in the early developmental period. People who are familiar with DSM-4 will know that we used a cutoff of 3 years. That cutoff is taken off now. It has to cause clinically significant impairment. Clinically significant impairment means there has to be impairment in self-care skills, impairment in learning, vocation, or socialization later in life. So that clinically significant impairment has to be there in the diagnosis of autism. Again, it's a huge change. I remember seeing a child, I should not call it a child, a 19-year-old adult in the UK. He actually was diagnosed with autism earlier on, but he was perfectly functioning normal. But we were following DSM-4 then, and we had to still make the diagnosis of autism for that child, though he was perfectly fine adaptively. Okay, so the adaptive ability has come in, and most of us developmental pediatricians like that component in. It should not be explained by intellectual disability or global developmental delay. The social impairment and social interaction problems should not be explained by ID. So this is actually the broad guideline. If you look at actually the DSM-4, it had included other neurodevelopmental disorders were not part of it. But we know currently that autism does not stand alone and can have other neurodevelopmental disorders as well. Okay. So I just play a short video so that you can. We will just discuss this once the video is over. As we can see, this is around a 2.5, 3-year-old boy. He is being given a car to play with. Okay, what is he doing? I don't know, any students are there online. Can anybody tell about the behavior that you're seeing here? So we usually, when we give actually a toy to a child, we usually expect the child to play meaningful with that. Okay. The development of play also is very well described over time. It moves from cause and effect play, explorative play, and then move on to different stages of make-believe play. So when we give a toy to this especially a car to the child, we expect the child to play, broom, broom, something, or, roll the car up and down, something, meaningful. But instead, he is actually having a repetitive play pattern where he is rotating the wheels again and again and again. Okay. So I couldn't play the sound here, but he's being called by the psychologist who is sitting behind, and he doesn't respond. His father calls him, and he doesn't respond to his father's call. So we actually need to specify in the current diagnosis whether this autism diagnosis is going along with any intellectual or language impairment. They can be associated medical, genetic condition, or sometimes environmental factors like lead toxicity may be there. It can have neurodevelopmental or behavioral disorders also can be seen commonly with this. And it's sometimes we see them associated with catatonia as well. Something I really like about, there is actually a support level that is come into the diagnosis itself. So on different domains, we say how much support the child requires. So level 1 requires some support. Level 2 requires substantial, and level 3 requires very substantial support. So let's look at social communication. So initiation of interaction has difficulty and atypical or unsuccessful response to social approaches, and some non-verbal communication is there. And we can notice these children without supports. They will become more obvious their difficulties, but with minimal support these children can actually do well. Same way, restrictive and repetitive behavior also, different levels are classified where how much support is required, how much inflexibility, coping with change, and repetitive movements. So summarizing the approach or the diagnosis of autism, there are two main components of autism diagnosis. The first one is social interaction and social communication difficulty, and restricted and repetitive pattern difficulty. In the social interaction, social communication, like social interaction includes how the eye contact with the person is, how the response to name call or any social overture is, how the child himself or herself initiates a social interaction. All these are part of social interaction. Okay. Social communication is how they respond to an initiated conversation, how they initiate communication with us. All these are parts of the social communication. Restrictive repetitive behavior can be repetitive, humming, hand flapping, jumping, spinning around. Some of them have lateral eye gaze. Some of them have sensory issues. We hear children having difficulty with nail cutting, hair cutting. Some of them have difficulty with mixie sound, even the Hoover or the, vacuum cleaner sound or the pressure cooker sound. So a lot of sensory issues also are incorporated into the restrictive repetitive behavior. I must also tell you that sensory issues are being highlighted more in the DSM-5 criteria. Okay. So now let us move on to how we approach a child with speech delay. Any child who comes to us in any clinic, it can be an immunization clinic, a general physician clinic, or a pediatrician clinic, or a GP clinic, or is even in a consultant clinic, it's always good to ask for what are the developmental milestones in the child. Roughly, children walk around 1 year of age, speak around 1 year of age. They speak 2-word phrases by 2 years of age, and they usually speak almost fluently by around 3 years of age. So when they don't do that, and we should see how delayed they are. Instead of speaking, let's say, around 10 words at 1.5 years of age, a child may speak only 5-6 words. That is acceptable. But if a child doesn't even initiate any social interaction, does not respond to name call, as even some children we see poor eye contact even as early as 6 months of age. So all these are red flags in autism, and any child who comes to the clinic with a speech delay, we need to approach them as per this flowchart. First important thing is actually to see how the nonverbal behavior is there. How is a child? Is a child looking at us? Is a child preferring to be alone in one corner and doing some spinning or some activities by herself? Or child is aware of the environment, interacting with us, or knows this is a new person, and stranger awareness, anxiety, all these components may be there, but age appropriate non-verbal behavior is shown. That is good. So if that behavior is shown, then we should check hearing. We should not forget that speech delay is caused by hearing impairment in a significant number of children. So hearing impairment, we should not miss out. So check with small, sound makers. You can tune it with an audiometer and see how the decibel levels of the sound maker is. The toys also can be used. If there is in doubt, always ask for a hearing test. Suppose a non-verbal behavior itself is bad. The child is, very anxious of the setting, spinning behavior, repetitive behaviors are seen. We should usually move on to the next one, which is usually checking the motor skills and also assessing the social interaction. I will move on to the motor skills. When motor skills also are affected, that means there are two main domains affected. Language domain is affected and the motor skill domain also is affected. Then we think, oh, is this child having global developmental delay rather than having a predominant or a prominent speech delay? I hope that's clear. Then when the child is, having a poor non-verbal behavior, you go ahead and see how the social interaction is. Oh, great, social interaction is good. Child is responding nicely, interacting nicely. And then if that is good social behavior, again, come back to see whether the child belongs to a global developmental delay or prominent speech delay. There are a lot of differentials for prominent speech delay. I will not go into that. The auditory processing disorders are a big topic in itself. I will not move into that. But when social interaction and nonverbal behavior are affected, we see whether there is stereotypy or restricted interest or sensory issues are there. Restricted interest can be they like only music, they like only talking about dinosaurs. We have seen children who like trains a lot or vehicles a lot or stars a lot. They have specific interest or cars. So they have specific interest, and this gets very badly disturbed if they move out of that interest. If that is present, so you are fulfilling both main criteria of social interaction and communication impairment and restricted and repetitive interest. So that group belongs to the autism spectrum disorder. Suppose we don't see that, it's only social interaction and communication is affected, and there is no specific sensory issues. We have to be very, very careful of sensory issues. We have to do 2-3 assessments to see if there are no other sensory issues, because sometimes in one setting it may not be possible. So such children are suspected to have a condition known as social communication disorder. This term is a new term. It was used earlier as semantic pragmatic disorder. Semantics actually is meanings, and social use of language is limited. It's again another topic. We will not go into that today. It's important to look at the comorbid conditions. Very, very important to look at environment. Okay, how the child's environment, how much e-media has been used. So we see that children who are exposed to a lot of e-media in the early childhood, it looks like they are at a higher risk of having social interaction and communication difficulty. In such situation, you try to optimize the environment. We see a lot of our children actually making fantastic gains once we optimize the environment. Stop all TV, mobile, not just for the child, for the whole family. So it is like no serials, no work from home for parents. So all these are curtailed. Actually, children improve a lot. Look for dysmorphism. Very, very important to look at sleep. I remember 2 years ago, the INSA meeting I attended, they dedicated one whole morning session actually for sleep. When I started working in autism, they used to say autism spectrum disorder has comorbidities as sleep disorders. But we now know sleep problems actually can precede autism symptomatology. And feeding, again, is a large concern for these children. So shall we move on? So what are the measures that we can use in these children? MChat is actually a very, very simple tool that we can use. It gives you red flags. It is available. We have Indian scales available. That's the Indian scale for assessment for autism. So these are screening tools. Even if I may say a simple screening tool like a Trivandrum developmental scale or a Denver or even a checklist, ages and stages questionnaire, all these can be easily done in an OPD setting. And any of these can be used as a screening tool. And if you have a doubt, you can just move on to an MChat. And then a definite diagnostic tools are DSM-5 is one. But we in our settings use more of Childhood Autism Rating Scale, that is CARS, Autism Diagnostic Observation Schedule. It is an observation that we do with the child and the family, and different modules are there for us to assess. Same way, Autism Diagnostic Interview revised. So what is recommended is actually we should use a subjective and an objective measure. Okay. So subjective measure is I take an interview, I ask parents, and I see, okay, this is a history wise, this is how it is. In objective measures, we are actually evaluating the child in a clinical setting or in a proper setting. You evaluate the child, both subjective and objective measures are there. It is comfortable to call as a possible or probable diagnosis of autism spectrum disorder. NICE guidelines of the UK clearly say it is recommended to have both the subjective and objective assessment. And we have the IndiaClen tool for the INT-ASD, again developed by an Indian setting. So all these scales can be used, but most of the professionals sometimes fall back on the DSM-5 criteria for diagnosis. So coming to the updates, I know I quickly went through the diagnosis because I thought we will concentrate a little bit on what is up to date in the field of autism research, as well as what is relevant for interventions in these children. There are a lot of updates. For want of time, I will be just quickly looking at epidemiological changes, causative factors, a brief approach outlook, and interventions and comorbidity. Before I move on, let me say the long-term outcome. I will not be talking in this in detail, but studies have shown that 20 to 25% children with autism can completely recover. Okay. So we see almost around 70% of our children definitely improving. I can't say all of them 100% recover. All of them make gains, and let me say conservatively around 10% of our children will completely come out of autism diagnosis. And that majority of that group belongs to a suboptimal environment group. When we first see we diagnose autism, and maybe 6 months later, they completely move out of the autism spectrum. So long-term outcome for these children is not as bleak as it was shown to be earlier on, and some of them do extremely well. We are happy. I hope some people ask me questions. I'm very happy to talk about this. This is Professor Gillian Baird. She has commented a lot on epidemiological changes. There is a suspected increased prevalence that we are seeing in these in epidemiological studies. Whether it is because people are more aware of it, we are picking that up. But definitely we are saying, 1 to 2% of our population have autism features. In South Korea, there's actually about 2%. Okay, so that out of 100 children you see, 2 to 3 children have actually autism symptoms. There are different theoretical models. I wish I could spend some more time on this. This is not an exhaustive list. There is actually umpteen theories proposed about autism. I will just quickly go through some of these. Mind blindness theory says that a child with autism do not understand what goes through the mind of another person. Okay. For example, I wish I could see all your faces. Then I know whether you guys are feeling bored or whether you enjoy the talk. And many times as speakers or teachers, we modulate our talk according to how we perceive the audiences. But unfortunately, I can't do that today. But children with ASD are completely blind to what others think or feel. So this is actually also known as the theory of mind principle in autism, has been originally proposed by Professor Baron Cohen. And executive dysfunction theory, again, we see children with autism have higher order skills deficit. Executive dysfunction is there. Mirror neuron, many a times if I go to a restaurant with one of my friends who is more familiar with that setting, I usually look and see what that person is doing and try to imitate her. And so there's a theory that says, okay, mirror neurons are deficit in these children. Weak central coherence theory is by Professor Uta Firth. And what she had proposed is, when we look at a picture, we have a central coherence, but that is lost in children with autism, and they concentrate on specific things, maybe the music or maybe the color of that painting. And similarly, a lack of top-down control. Extreme male brain theory, there has been a theory in between that has come with increase in utero testosterone exposure and the 2D, 3D finger ratio, with the hypothesis that children are exposed in utero or ex utero to maybe more testosterone, and the brain develops into an extreme male brain format. Then there is an empathizing and systemizing theory. Women are supposed to be more empathizing, or let's say be more sensitive, while some higher order, high functioning people, scientists or technocrats, they're all, or even some of us doctors, actually, we're all very systemizing. Okay, we put them into categories, we subdivide it. So autistic individuals are supposed to be very highly systemizing and less empathizing. Then the sensory integration theory that says that there is actually a sensory impairment and a sensory integration difficulty in these individuals. Bayesian model theory is a most recent theory proposed. It's been proposed by Elizabeth Pellicano. She belonged to the Institute of Autism based in London. She proposed that children or individuals with autism do not have those inbuilt models. So we all think, okay, in this setting, well, how should I behave? So we all have a model in our brain, but those models are deficient in these children. So I have put in some of these in a way, looking at the triad of autism and where some of these theories may fit in. Let me tell you, autism is very, very myriad, complex, and let me say, throw surprises at each time. One exclusive theory, maybe too short-sighted to explain all features of autism. So this is actually the triad of autism. So there are social impairments, communication impairment, and restrictive repetitive behavior. So the theory of mind deficit may explain some of the social impairments and communication impairment. Same with maybe mirror neuron theory. Some of the executive dysfunction, the child may not be able to do some of the higher order skills, so may revert back to doing the same lower order things repetitively. That also may explain the Bayesian theory. And sensory integration, we know studies have shown that higher sensory disorders, higher the restrictive repetitive behavior, and weak central coherence also can pitch in there, where they forget the bigger picture and they look at only repeating. Remember the child we saw going on, spinning the wheel of the vehicle. So that's a weak central coherence to realize that this is a car, I need to play with it. Okay, all right, guys. So I think now we will just look at what we know about the causative pathway of autism. A lot of parents ask me, Doctor, what has caused this? There is again no single cause. Again, this is actually a very, very varied presentation for us to call a single cause for any of the autism. But what we know now is there is an interplay between gene and environment. A lot of people use the term epigenetics. It is not just genetics, not just environment, the gene-environment interaction. So we know this is actually the brain development till the second year. This is known as the golden time, or the first 1,000 years of life. And starting from conception till the second year, that is the first 1,000 days, very important for brain development. So neurulation, neurogenesis, neural migration. See, I'm not going into the details, but the overall brain development, axon generation, synapse formation, pruning, myelination, everything happens in that first 1,000 days of life. So any insult, let it be genetic risk, let it be in utero risk, ex utero risk, environmental risk, actually affects the brain, fine-tuning of the brain, if I may say so, and can cause different neurodevelopmental disorders like cerebral palsy, autism spectrum disorder, attention deficit hyperactivity disorder. This is actually what we understand of the causative pathway. Again, it's a very, very busy slide. So this is actually the timeline of etiological research. So if you look actually at etiological research, and the dark background actually gives us all the, the genetic research started maybe in the late 80s. And these are more medical conditions like, hypothyroidism in the mother, diabetic GDM in the mother. But if you notice, actually, there's a lot of these environmental studies coming in, the gray, the light background, And so there are a lot of environmental studies also coming in. So definitely there is a gene environment link strongly implicated in children with autism. I cannot leave without the gut microbiome axis. The gut microbiome actually is the in thing now. What comes first and which is the egg, which is the chicken, is very difficult to say. But we again know that genetic susceptibility causes gut dysfunction, microbial dysbiosis. There is an immune dysregulation and an immune theory proposed actually in autism as well. Overall, all these, including environmental risk, causes an abnormal brain development and function, and that may be linked to the gut dysfunction as well. Okay. This is another way of looking at it. The prenatal, it can be anything. Now, pesticides, phthalates, air pollution, maternal metabolic conditions, causes metabolic and immune markers, hormone markers, affects or modifies a gene expression. Okay, we know the genotype, phenotype do not match 100%, but definitely modifies genetic expression and can result in more diagnosis, more behavioral manifestation of autism. So the brain changes, what we see actually can be what all? Microstructural deficits. There can be a cell density changes. It can be macrostructural deficits. We sometimes see some of the genetic conditions having gray matter, white matter difficulties. And it can be a functional defects. It can be a connectivity issues. So when you look at autism spectrum, we'll come to comorbidities again. 8 to 30% have epilepsy. A significant number of children have sleep, mood, ADHD, ID, GI, immune dysregulation, and refractory self-injurious behavior. So it is not like there's one thing that just stands alone. No? If you look at the DSM-4 earlier, autism and ADHD couldn't coexist. But now we know that so many of these neurodevelopmental disorders coexist and can be quite detrimental to the optimal development of the child. So when you look at the causal pie like this, it can be a maternal infection, maternal illness, it can be genetic causes, it can be methylation factors, it can be environmental, or nutritional causes. So the multiple causal pies for each child. And it might be futile to say, okay, this is only one cause that resulted in this condition. Okay. So what are the comorbidities? There are a lot of medical comorbidities. We know that Fragile X has increased incidence of autism. We of late are seeing more children in Down's group also having autism. Epilepsy is commonly described. We see in neurometabolic conditions. Other neurodevelopmental disorders like attention deficit hyperactivity disorders, developmental coordination disorders. So we see a group of autism actually struggling to write, struggling to do things with their hand, and they require more support than a high functioning autistic child who is doing fairly okay. Specific learning disabilities also are seen. And some of them have neuropsychiatric disorders as well, like mood disorders and anxiety is very, very common in some of these children. And we really need to be open about some of these conditions when we see children in our outpatient services. So again, I have put it into one spectrum. Autism spectrum disorder can have multiple comorbidities, and it's important when we make a diagnosis of autism, rather than saying, oh, only autism, and we should also look at whether other conditions like sleep can be dealt with, feeding can be to some extent helped with, and some of the sensory issues can be helped with. So many a times, rather than we need to address social interaction, communication, and repetitive behavior, but addressing the comorbidities help children and families a lot. Okay. Now, how do we approach a child with ASD? That's what we do here. In our clinic, we do an ASD diagnosis by DSM-5. We definitely look at the intelligence and developmental level. We use the standard developmental profile monitoring. And we look at actually what are the comorbidities in these children. So all detailed evaluation of comorbidities. If possible, we look at the causal pi bar risk factors, but it's very difficult to 100% give causative association. What is very, very important, we make a pile of what the child cannot do, but we also look at what the child can do. What is the strength of the child and what is the functional status of the child? Even some of the, the very, very difficult children, they have actually a bright spot somewhere. So for us as professionals, it's our endeavor to look for that bright spot. So this is actually, now we come to some spotters to just spice things up. So this is a 2-year-old has presented to the clinic with a failure to thrive, has spastic diplegia, You can see the head size is small, retinal mottling, sensory neural hearing loss, and autistic traits. Does anybody want to say anything? Come on, guys. So this is a child who is having a spastic diplegia. Retinal mottling is a little bit tricky for us, You're wondering whether it's a torch sequelae. Then you look at this face, what are you seeing here? This is actually, the child actually has photosensitivity, okay? So this child has a cocaine syndrome. So it is actually a progressive condition. They have photosensitivity, progressive spastic diplegia, and retinal mottling and progressive sensory neural hearing loss. So even a child who has any disruption to the normal neurological development can present with autistic behavior. So it's important for us to see what is the overall picture. Definitely as pediatricians, it's important for us to see. This is actually a classic spotter. 9-year-old, uncontrolled seizures, autism spectrum disorder, and intellectual disability. Anybody wants to say what we are seeing? Madam and all will know, so we will ask the students. Come on. Don't let believers down. So this is a typical adenoma sebaceum that you are seeing. It looks like, pimples, right? The child is having a little bit pimple on the face. And this gives you the spot diagnosis of tuberous sclerosis. Okay, so you look for other neurocutaneous markers, and you look for, if possible, do imaging to look for neurological tubers. And these children are very, very high risk for autism spectrum disorder, but that doesn't stand alone. It's actually a combination of seizures, the underlying TS complex, and intellectual disability. Okay, so again, this is not a very typical presentation when we say. This is actually a little atypical presentation of a common condition. So 10-year-old boy has come with autism spectrum disorder, intellectual disability, lot of behavioral needs, very difficult to control behavior. Any comments? But when we look at this child, child looks little obese. You can see prominent nipples, and little obese, prominent abdomen. So you're seeing like a little obese child. So you just think of other, conditions, Bardet beetle and all these, no polydactyly and Prader-Willi, not like that typical. But when we did any male autism spectrum, difficult to control behavior, we have to rule out a Fragile X. Not just for the next pregnancy, for the mother's sake as well. So this child actually was Fragile X proven. We see a lot of children with Fragile X. This is a typical presentation of Frag X. I'm so sorry because, some of these I had to hide for patient privacy. So Fragile X, they are usually tall statured, okay? And they have this prominent ears. Can you see the prominent ears? They have a prominent jaw. And we have seen some couple of Frag X sweet autistics, but most of them have difficult to control behavior. Okay, so so very commonly associated with autism. Again, this is a 6-year-old girl who has come with autistic behavior. When we took the history, they came from Bangladesh. When we took the history, we realized actually there is a little bit of a developmental regression. I want you to highlight, I want you to look at the face of this child. There is a mild coarseness of the face, okay? It is not like a real coarse face. Height looks all right. There is no bowing of legs or no abnormality of the bone seen very clearly. You can appreciate a little bit of a hypertrichosis, prominent eyebrows, little bit of hair here, there, a little bit here. So when we are seeing an autistic child with a little bit of regression, mild coarse facies, no organomegaly, you should do for an urine MPS spot test. And this is a girl with Sanfilippo. Again, behavioral management is difficult in these children. Parents were heartbroken, but I sometimes think it's good for us to be honest with them. They keep coming every year, but every year is sad to notice that she is going down a little bit. Again, this is another child. This was around a 1-year-old boy from West Bengal who has come. Irritable cry. You can see this hair, very thin hair, hypotonic, no eye contact, very touching itself, very irritable. This child had vitamin B12 deficiency. We supplemented B12, and 6 months later, child is able to sit by self, standing with some support. Still hasn't put on weight. Okay, look, but even then, the temperament of the child has improved. So, as sometimes think as pediatricians, we should pick up these treatable conditions if possible. And many times we see B12 deficiencies are very common in um, uh, some of the population. Even non-veg eating population, we see B12 deficiencies. So if that can be taken care of, most of the children improve. Let me tell, there is some impairments remain, but parents are quite happy with the intervention. Again, another spotter for the medical students. I'm definite. This is a girl who has come to us, maybe around 2 years of age. You can see the head being a little smaller side. This is a CT brain showing. So you can see multiple calcifications. Okay. So when you're seeing calcifications like these, your springs and you think of a torch infection. So any presentation we can actually see in a child with autism spectrum disorder. So this is another child. A lot of dysmorphic features were there. Again, lot of stereotypy, and even after intervention, child was not making much gains. Then we think, oh, is there any organic basis? Actually, you can see a lobar, hemilobar holoprosencephaly, where there is a semilobar holoprosencephaly, where you can see the connection between both the hemispheres here, where septation is not complete. So why I say that is just looking beyond autism to look at what are the other comorbidities in this child. We are fortunate to be part of an ICMR grant. We looked at around 80 children with autism and segmented their brain to evaluate. It's a very beautiful software, gives you all parts of the brain, and a very interesting study where we can analyze different parts of the brain. And what we found out as the typical, I'll just summarize it, the typical, typically when we see in typical developing individuals, most of our language areas are left dominant. Okay, even for children who are left-handed, our language areas are left asymmetric, but the typical left asymmetry is lost in autistic. So what is the implication for us? So left lobe or left language areas are auditory dependent, while the right language areas are more visual dependent. So instead of using pure auditory component, we suggest to use a multi-sensory communication intervention, not just verbal. Use visual, use tactile, use even vestibular or jumping around. So it's like, rather than purely concentrating on auditory, which is actually a weakness for these children, a multimodal communication intervention works better. So typical left-right asymmetry in higher language areas were absent. So there was an increased right asymmetry of pars triangularis, which is actually the expressive language area. And we found out that the higher atypical cortical asymmetry was more with increase in autism symptomatology, and this paper is published as well. Coming to the medical evaluation in autism, definitely we have to ask for family history. So X-linked, FAGX, you ask for how any maternal family history, and any history of regression. Speech regression is seen in 1/3 of children with autism. So that alone does not warrant a complete evaluation. But if you think it's significant, you can evaluate. Definite history about environment, e-media, how parents are interacting, dysmorphic features, microcephaly, and any neurological signs are there, we have to evaluate. And I prefer to actually follow up the children and see how well they are gaining over time. the typical ASD should significantly improve. If there are no gains, then we really want to evaluate whether any other causes. So this is a chapel in CMC. Those who are familiar with CMC will know this. And this was built actually in the Great Depression of the 1920s. And Dr. Scudder that time didn't have resources to build the chapel. So she went on collecting $1. And so this chapel was built with $1 contribution. So when we all can work together, miracles can happen. So coming to interventions, I'm running late, so I'll just try to sum it up quickly. This is actually a Cochrane review of interventions in autism, and there is very low, moderate to low evidence in most of the intervention plans. So there are a lot of interventions, applied behavior analysis, discrete trial training. I will just skip this little bit, okay? And what is the current recommendation is the NDBIs, okay? NDBIs as naturalistic developmental behavioral interventions. So if you look at the history of interventions, there were two groups in autism interventions. It was very interesting to go for these international conferences because there would be a group with behavioral intervention guys and the developmental intervention guys. There usually will be a clash between both of them. This is right, this is better. But what we know now is there is, as I said, there is no definite theory or causative factor for a child. Same way, there is no definite one intervention plan for a child. So if sensory issues are there, you use sensory integration therapy. If more behavioral problems are there, you use ABA principles. If more developmental issues are there, you use more RDI, it's relationship development, individual-based intervention. So you use more developmental intervention. So it is actually a mismatch, it is a mixed match of different plans that we should do. What is best for the child? So I'll go through each component on this. Naturalistic means as much as possible, we should try to work in the natural settings, that is home-based. So we know that as much as possible, let parents be trained, it has to be home-based, less therapist-based interventions. But it is difficult for parents, I agree in the beginning, and the long-term effects are better with a home-based, naturalistic, a combination of developmental and behavioral interventions. So this is actually, I pulled it out from JAMA Pediatrics. It's a November article, just recent articles. So what are the intervention recommendations? There is evidence base for naturalistic developmental behavioral interventions. They are useful. There is limited evidence for greater intervention intensity. Why I say I didn't cover this bit. There is actually the early ESDM, we call it, the early stage Denver model, which suggests about 20 to 25 hours of training for the child. It's quite an intensive training. And there is some evidence, but let me say it's only limited. Idea is to have an overall plan for the child and implement it at home with the help of the parent. So it has to be tailored to families and as much as possible integrated multidisciplinary supports, because sometimes parents complain, oh, we go to speech or we go to OT and we go to the doctor and we go to this person, SI. So we get confused. As much as possible, try to integrate that and give parents one overall viewpoint. So what do we do here? We have an eclectic model. We pick and choose what is best for the family. We have a multidisciplinary team who works with the families. We look at the development, behavioral, functional level, look at the comorbidities, the risk factors. We make a plan for each level. So it is not just speech or language we work at motor skills, we look at language communication, sensory issues, social interaction, not just language, communication as well, self-care skills, learning. So, all these we combine together and make plans for each things and work with the family and parents. Why I say middle ground, a 100% therapist-led approach will not work. So some things we have to follow the child model. The child is happy to flap. You also may flap with them and teach them something along with that. So the middle ground actually works fairly well for us here. Parents are trained, are guided here. We have a huge workload. I'll just come to that. So we cannot afford to have long training programs. We give short training programs of maximum 2 weeks. We have started a model where we just started a 1 month for local families, and that has worked well as well. We are both inpatient and outpatient services, and we are very thankful to our child and adolescent psychiatry department. They have a longer 3 months training as well. So we see a huge number. This is our, I haven't put in the new latest one. We see around more than 20,000 children a year. And this is looking at the children who have come to the ward in patients. Overall, around 50% of children have autism. I just quickly go through it. We're hitting the 1 hour time. More boys and less girls. And just highlight seizures are present in around 25% of children. Sleep problem again in 25. Around 12% have feeding problems. And majority of them had some amount of more than 2 domains affected in the development. So when we looked at the baseline, 82% were boys, and majority of our children are less than 5 years of age, and seizures were seen in some of the children. So the CAS score varied between 26 and 43, and this is a baseline quotient of language and performance. So we did a chart review of our children to see whoever had come for a review after 6 months. So what is the response? So we have seen actually the language T-scores have improved by 6 points, and the performance T-score has actually improved by 9 points. All these are significant, and children improve. So I have put this slide to show that actually when given appropriate intervention, children with ASD actually improve. But let me say all this comes with, some issues, so that they have a high impact on family. Studies abroad show that autism has a higher impact than other neurodevelopmental disorders. We didn't see that. We saw that autism and all neurodevelopmental disorders have a high impact on families. In addition, if there are girls, okay, they are worried about girls getting married even when they are 3 years of age. Seizures, sleep problems have higher impact. When sleep problems are there, parents themselves cannot sleep, and it really causes havoc for the family. So this paper also again is published. So summing up the Vellore experiences, it is not anything of our credit. By God's grace, parents are involved and they are motivated, and that is a single driving point for the child's improvement. I want to highlight again that it is not anything that we do. It's actually God's grace and parents' involvement and motivation that gives the gains to the family and to the child. And I understand and realize it puts a lot of pressure on families and parents, and we try to our best to support them. Social support is important. I haven't put in this slides, but if you remember Donald, we talked about, no? Donald is alive and well. He is in his 80s. The first child described by Professor Canner. So he is alive. He has lived well. He is a golf enthusiast. He has worked and he has retired, and the society takes care of him. So as professionals, as lay people outside, we should have a support for these individuals so they can achieve their 100% potential. And the ability of the child, IQ, intelligence, developmental language level is important. Duration of intensive training. Some studies have shown it is important, but not just the duration. It is important to continue the support as much as possible. Comorbidities and risk factors are important. Coming to conclusion, ASD is a heterogeneous condition. There's high impact on families, so we have to take it very sensitively. Approach is as any other medical specialty. We have to take history examination. There's no replacement for that. Intervention models are evolving. We know now NDBI has more evidence. And over and above everything, our role is to hold hands and support parents and these families. I want all of us to be advocates for these children, not just autistic individuals, but all children with neurodevelopmental disorders. Can we be advocates for them? I want to play this video to give you a little bit more highlight on this. I don't know whether you can hear the sound.
We are all different, and that's wonderful. Some differences are easy to see: height, hairstyle, gender, eye color, and so on. Other differences can't be seen. Our favorite foods, gears, or special skills. Interestingly, the way we see the world is also different. For instance, what do you see in this drawing? Most people see a duck, but some of you might have seen a rabbit. Whichever you saw, you are correct. This is just a trick drawing to show you that all brains work differently. The brain is your body's computer. It works differently for all of us and controls how you learn. That's why we are all good at different things. How you feel, which is why we all feel different emotions. And how you communicate. Sometimes the brain is connected in such a way it affects senses and how we perceive and read situations and interactions. This is known as autism. Many people have autism, so it's likely you already know someone who is autistic. And for this reason, it's useful to know a little bit about autism. The special wiring inside an autistic brain can sometimes make the person good at tasks we may find difficult, such as mathematics, drawing, or music. It can also do the opposite, and activities we find too easy are incredibly difficult to them, such as making friends. The senses constantly send information to your brain about your surroundings and other people. However, when a person's brain and its senses don't communicate well, the brain can become overwhelmed and confused, affecting how they see the world. Picture yourself walking down the street. This is how an autistic brain may experience the same walk. Scary, isn't it? Sadly, in many cases, the person can't say out loud how they feel. So even though there's chaos going on in their heads, they seem okay on the outside, unable to ask for help. We will develop behaviors to help us feel calm in uncomfortable situations. We may look away, hug ourselves, chew our fingernails, fidget, our lips, and so on. Equally, autistic people develop behaviors that help them cope with these intense moments. These actions may seem unusual, but they're just their way to feel calm. When they happen, it means they are having a hard time. The kind thing to do is not to give them an even harder time by getting cross, ignoring them, or mocking. Remember, just because a PlayStation can't read an Xbox game, it doesn't mean it's broken. People with autism need friends who are willing to take the time to know them. With good communication and plenty of patience, everyone will be better off. People with autism are not ill or broken. They simply have a unique view of the world. And with a little support from their friends, they might just be able to share that view with us. Autism can make amazing things happen.
So, and I should give my thank you now, and thank you to the team who has called me from Believers. Thank you once again. And definitely the team here, we have a multidisciplinary team and nothing can work on its own. So I must thank all my the team members here in the developmental pediatrics units. CNC is blessed to have different departments that support us. I'm thankful to them. The families who visit us and keep their trust, and should thank them. And the children, they continue to teach us and bless us. And I should be thankful to the ICMR grant that helped us to do the brain study. Thank you all. Additional references are there here for your references. Thank you. Thank you all for your patient listening. I'm happy to take some questions if there are any, or have I zapped you all? Madam, I think you may need to put your, unmute yourself.
It is unmuted.
Sorry for that interruption. I had a problem with my system, so I was not able to unmute. Ma'am, thank you so much, ma'am. That was a wonderful talk. It was a great privilege to have you with us, and we really thoroughly enjoyed your talk. Beena, ma'am.
Thank you.
Yeah, sorry for that little lull, okay? It was unintentional. My mic was not unmuting.
Sure.
Sorry for that.
No.
Yeah.
That was an amazing talk. And let me hand over to our Girija ma'am for the moderation to take questions and to take things forward. Ma'am, on the unmute cheyavo, ma'am. If you can unmute your mic, please. Dr. Maman, can you please help with this? Dr. Maman?
So has to unmute from her side. I am asking her to unmute.
Okay, okay.
So I am asking her to unmute.
Yeah, ma'am, you're live now.
Yeah. Dr. Beena, it was a fantastic presentation. It was, each slide was information loaded, and that concluding video was excellent. It was very touching video. It was very informative also. And I'm glad to inform you, few of our students have answered their questions, SPOTUS, tuberous sclerosis, and
Oh, wow, very good. Good show.
and few have answered intrauterine infection like toxoplasmosis.
Good. Yeah, it's a total calcification we see. So you're right, yeah.
Because it was such a crystal clear, I think there are only few questions. Dr. Ria has few questions. That is, how do we answer the anti-vaccine lobby who says vaccine causes ASD?
I will not go into the details of it, but I think as many of us know that MMR, there was a conflict of interest for the person who published it, and that paper is actually withdrawn. Many times I think it is a timing. Okay, 1/3 of children with autism, we see some amount of speech regression. And you're giving MMR at around 15 months of age. Developmentally, we
Please unmute ma'am's mic.
Sure. Yeah. Now I think I'm unmuted. So it is actually the timing. So even between 1 to 1.5 years of age, if you look at developmental language, how it develops, children speak some words and they forget it. It is not fixed in their brain yet. It is like, okay, I go to America and pick up a couple of places' name. I will forget it unless I repeatedly see that place again and remember things. I will just remember and tell it for a day, and the next day I will forget the place. The same way, between 1 to 1.5 years of age, the language use can, even in a normally developing child, that word can go. They may say water and vellam, they may say, and 2 days later they may not remember the word. That is normal. So it is little difficult actually to tease this out. But we know definitely there is no vaccine contribution to autism. That is not at all anywhere there. More than vaccine, actually, the air we breathe may be causing more problems. Thank you. Hello,
Beena.
Anu.
Hi, Beena.
Hi,
I'm
Anu.
really proud to say that Beena is my classmate and a very dear friend. And after Beena, your talk, I kind of think that even I might have a little bit of autism, and a lot of people that we know also might have a little bit of problems with communication and all that. Just wanted to ask you just one thing. When you said about the asymmetry of the brain, there are lots of studies about this functional MRI, Is there anything that has come out of it? In functional MRI, is there something contrary that we find in autism?
Sure. Thank you, Anu. It's actually a very, very layered question. Let me answer one by one. Definitely, a lot of us have autistic traits. Okay, so even now, my family, Bujal is going on there. So for me to concentrate on this presentation, I am a little bit autistic. Okay, so the autism helps us to concentrate on our work without getting distracted by a lot of other stuff. Okay, so very high functioning scientists, high functioning musicians, all are a little bit autistic. So that autism gives us all a little bit edge to function with that extra concentration. So there's nothing wrong in being a little bit autistic. Okay. Problem comes when it affects our day-to-day functioning, when it affects our ADL, self-care skills, our vocation, our learning, our relationships, then that is when I think, so it is beautifully been elucidated in the current DSM-5 criteria. Second, functional MRI. Functional MRI, there are lots and lots of studies that have shown that there is higher language area problems, there is executive function problem, but there is also a group who criticizes functional MRI. I will encourage everybody to go and look at functional MRI study in an Atlantic salmon. Okay, so they took a dead salmon and they did fMRI on this salmon and they showed different pictures to the dead salmon. And I found out that the salmon is better in identifying one set of picture than the other. Okay, so there is a lot of criticism for fMRI. So problem in doing fMRI in children with autism, it is very, very challenging because less than 8 years of age, fMRI, the child has to be alert. It is very useful, let me say, when we are doing tumor surgery. I have a brain tumor in my frontal lobe. I need to see, the surgeons need to see whether my Broca's is involved. Fantastic to do an fMRI. So the Broca's is spared, they can go ahead and take it out. But in children, when we are doing fMRI, less than 8 years, especially ASD children are very, very sensitive. But there are lots of studies that have come up and they all show that there is language deficits, executive function deficits. And again, they have shown when a sound is heard, it is not heard in the typical language area. It is heard in different parts of the brain. So they are overcompensating for some deficit. But what is the consensus is, whatever it is, there is some organic underlay for this autism. That is why it's called now a neurodevelopmental disorder than a pure psychiatric condition. Okay, so there is an underlying developmental issue. I hope I answered you.
Sure.
Thank you for asking that question.
Thanks.
Thank you so much, Beena ma'am. And I would like to register and thank here that it was our senior endocrinologist, Dr. Anulekha Mary John, who just came live. And it is she who connected us with Dr. Beena ma'am and facilitated this amazing talk. Thank you, Anulekha ma'am. Thank you so much. And I would like to invite our beloved director and CEO, Dr. George Chandy Matitra, sir, who is live, to come in with his perspective and to just say a few words.
Beena, thank you so much. That was absolutely wonderful. Enjoyed every bit of it. Thank you very much for giving this to us. We really enjoyed it. Thank you so much, Beena.
Thank you, sir.
Thank you so much, sir. There are a few more questions. Over to Dr. Girija ma'am for the moderation. Ma'am, can you please unmute your mic? Yeah, that's fine, ma'am.
A question from Dr. Ria. What about gene therapy in ASD?
Let me answer that in multiple ways. If we know that there is a single gene that is causing it, it's very easy to, for example, Duchenne muscular dystrophy, we know the DMD gene. So definitely it is like, okay, we can go ahead and do intervention for that. If I may say something like diabetes, can I go ahead and do gene therapy? It is like a multifactorial causative pathway, right? Same way, this also has multifactorial causative pathway. But there have been a lot of studies and things that highlight stem cell therapy, gene therapy. But let me say the evidence is suboptimal. So what we know now is there has been a scattered studies which have shown it is safe in individuals with autism. That is all we have got from all over the world. There's even from the US. But Indian Council of Medical Research has brought out a book headed by Dr. Maman Chandi where stem cells can be used. None of the neurodevelopmental disorders, including CP or autism, actually even figure anywhere near that. Okay, so at this point, there is no evidence to say that any of these gene or stem cell therapy is effective. I also always tell the example of driving or swimming to parents. If I don't know driving, what medicine or what gene therapy can I take to drive, Or if I don't know swimming, I need to get into water and do it, there's nothing else to it. So this is actually a skill deficit in the child or the individual. And our idea is to reskill the individual. That is the idea. So rather than we beating the bush and saying a lot of things, but let me tell you, there are a lot of professionals who make money out of it, and I think the legislation has come in to look at all those factors. At this point, there's no evidence.
Dr. Bina, I have one question. You mentioned about the gut microbes and relationship with. Is there any food that you can recommend from the studies? You recommended vitamin B12, multiple vitamins can be supplemented in any neurological problem, especially metabolic. So is there any cocktail like that for ASD?
There has been, when there is deficiency, any of these are good. When we have B12 deficiency, definitely B12 is good. And most of the children we see are iron deficient, so a little bit iron supplementation. So, but studies have shown this high dose multivitamin therapy actually has no use at all. And also a lot of discussion has gone around the gluten-free, casein-free diet, GFCF diet. But again, there is no evidence for GFCF diet. We see maybe a couple of celiacs we have seen who have developed autistic. Definitely in that case, okay, you suggest specific intervention, but nothing to say that all autistic children should have a GFCF diet. No, there's no evidence for that. So, but what we suggest actually is to take as natural as possible. So cut down on your highly processed food, including sugar, your, kurkure, Lays, Pepsi, biscuits, cookies. I think the kids are now on this, the junk food diet. Definitely there will be some implications and some effect on the child's behavior. So we usually say as much as possible, home cooked food, use natural elements, use more of our spices, turmeric. See, some of these things are anti-inflammatory in nature. And there is actually an immune inflammatory model to autism. So there's no harm in giving a little bit extra turmeric or extra garlic, but there's no evidence to say that you completely exclude milk because the child is autistic. Cut down, we see a group of people from West Bengal having 5 times milk diet. That also is not healthy. A balanced home cooked food. That will be my recommendation. Thank you.
Thank you, Dr. Bina. Over to Dr. Jacob for the concluding remarks.
Ma'am, there are a few more questions. What is your take on sensory processing dysfunction in ASD, ma'am?
Sensory processing dysfunction has come to the forefront now. If you look at the DSM-4 and all, we didn't give that much importance to sensory issues earlier. But sensory processing comes under the restrictive and repetitive behavior now. It's a separate thing that we need to assess. We see more, we have done a study in our group, in a small group of our children here. Almost more than 90% of children have some sensory issues or some or other. Most common we see is the auditory hypersensitivity. So even sometimes we see children find it difficult even with this fan sound. Neither am I hearing the fan that I have put on here. But some children, they close their ears even with the fan sound. So auditory hypersensitivity is the commonest that we have seen in the cohort that we have studied. But sensory processing disorders have come very much into the forefront, and for all our children who get a detailed assessment, we do sensory assessment for all of them.
Sorry, there are two more questions. One is any relationship with excessive media exposure from Dr. Jijo.
We see actually a relationship with language development and excessive media exposure. See, children, I sometimes think, no, there's nothing that can replace a basic child development environment. Basic child development environment is I need to sit with my child, play or interact and have fun. See, mind you, our parents never did that with us, but we had a very open, ground, open, backyard, lot of other relatives, lot of other friends who took that role. Now, most of the families are nuclear, only parents and the child. And even we see many times parents also are addicted to mobile. Child also is addicted to mobile. Then where does the child learn social interaction and communication from? So that opportunity cannot be replaced. Okay, so we usually say completely stop e-media and then increase the social interaction and communication. And many times we see improvement. But let me be careful. It's not like, okay, we have done a study in other group as well. A lot of children have e-media exposure and higher behavioral problems, higher communication problems, higher learning concerns are seen with that group. So my suggestion, humble suggestion to everybody, including ourselves, cut down on the e-media usage and have more real experiences and interactions.
Ma'am, I would just like to quip in. My son is almost 2 years old and I have not exposed him to any media, but I've got immense pressure from a family. Even my wife says, why don't we show him little bit of screen or little bit of TV? But somehow I've been putting my foot down and succeeded in a way to prevent all that. And I think I see results. He's more interactive. He's more active in his physical activity and stuff.
Good for you. Good for you.
Yeah.
Because we see, because we have seen children who are extremely capable. I had a boy who is actually a polyglot. Polyglot is like he speaks multiple languages. So he speaks around 10, 15 languages. He has come on television.
Oh.
He is autistic. He knows writing some 5-6 languages. So what I try to say is, he learned all this from internet and computer and all. And sometimes we see very highly skilled children. But for me, I sometimes think when they are young, build the soft skills. So they can learn language anytime. They can learn multiplication, addition anytime. That social interaction, communication, the basic skills, in Malayalam we say chottele, Sheelan chodala vare, like this, what we do in the young age, it stays with us, that behavior stays with us. So that is what we want to stress on. Thank you.
Ma'am, and in UK, I think there is a major problem that is brewing, especially coding at childhood. I hope you would have read articles. Children are made to do the software coding at 5 years of age, 6 years of age. And I think their childhood is destroyed with all this.
It is not just in the UK, Jacob. It is actually there in well. There has been a huge propaganda, I think, because I keep getting messages. So I presume others also may be getting it. So of adding on, training children to code. So I sometimes think it has to be a balanced thing. If somebody wants to learn to code, great, go ahead. As long as it's not affecting their life, it's fine. But in our brain can do only that much. So all of us as parents and individuals, we need to take priority. So I am no one to criticize or comment on somebody else. If they're happy with that, is great. But
2 questions I will combine. Dr. Carol has asked about the role of probiotics, and Irene has asked about any role for mother with amyloidosis to a child having autism.
Sorry, mother with? Sorry, I didn't get that.
Amyloidosis.
Amyloidosis. Okay. So probiotics again, studies haven't shown any evidence. But you want to give, I sometimes tell parents, if there's something that you can find in your home or in your garden which you think you are eating, please go ahead and give it. But don't spend, let me tell you, there are a lot of things available in the market. We get also pharmaceutical guys coming to actually promote this. Expensive stuff. I really do not find any evidence for all those things. But you think, yeah, some of these definitely, okay, diarrhea is there. There's no harm in giving little lactobacillus. So there's evidence for that. And but in the case of autism, this gut microbiome is just coming in. And there has been again a theory that has been proposed. Gut microbiome, people have proposed it for neuropsychiatric illnesses. Everything is there. We really do not have any evidence which came first. Is it association? Most probably it is an association. But as long as you are eating it and you are happy to provide it, I have nothing against probiotics, but I will not suggest it as a treatment for autism. Amyloidosis, any condition that can affect fetal development. Again, amyloidosis depends on how severe it is. Any condition that affect the neuronal development of the child can technically affect and cause autism. But let me tell you that we see a lot of people with multiple concerns and children are all fine. More than amyloidosis, I may say that we see actually maternal hypothyroidism in the antenatal period. We see that actually having a lot of polycystic ovarian disease. In
So I think we have discussed all the questions.
Yeah, I think the connection got cut with Beena ma'am. Maman, is ma'am trying to log in? Dr. Maman, if Beena ma'am is...
No,
if
I
she's,
am just online and she's not.
all
not
right,
trying.
she might try now. Please do let her in. We'll wait for a few more minutes.
Sure, sir.
Are these glitches happening all the time, Dr. Jacob?
No, sir. No, sir. This is the first.
Yeah. So these are the things we have to watch out for.
Yes,
Maybe
yes.
have, especially when you're trying to do it from different locations, all the more reason we have to be very careful, no?
Definitely, sir.
It's
Sir,
because the speaker...
it's actually a weak connection from ma'am's side, sir.
Yeah, it's very soft. I had to struggle to listen. Despite my Wi-Fi, was it soft for everybody?
It wasn't, sir. It was quite good, sir.
It's quite good. So there was no
So
problem.
Okay. Dr. Girija, thank you so much. Good to see you again, and looking forward to your return.
Ma'am, your connection got muted. Girija, ma'am. Ma'am, can you please unmute? Yes,
At one point, you muted all of us. Somebody muted all of us.
True, sir.
Did
Everyone
you
was
know that?
Yes, and we couldn't unmute ourselves.
Yes. So,
Yes.
Maman, there was a problem in between when we were all muted. And as Anu said, we could not unmute ourselves.
So that's because for the past, in the previous webinars, we were getting disturbances from the audience. So it was a common practice that we mute everyone and only allow the speaker and the moderator and Jacob Jasuran sir be unmuted.
Yeah, that's fine. That's okay. That's not a problem. That's not. So it was something that you deliberately did.
Yes, sir.
No.
Yes, sir. That's
Yeah,
a
that's
usual
okay.
practice,
That's
sir.
That's the usual practice.
Yeah, that's fine. That's fine. That's fine.
Okay, I think Beena ma'am is not coming online. So that was quite a commendable session. It was really an eye opener for all of us. And I would like to take this opportunity to thank Beena ma'am for that amazing talk, and Dr. Girija ma'am for her admirable moderation. Thank you, Girija ma'am.
I think
And
Veena might be coming back. She's trying to get back, but she's not able to. Can somebody admit her, please?
She is just getting in, ma'am.
okay.
She thinks that we have had enough of her. It's not so.
Maman, have you let her in?
Yes, sir, I have let her in.
Is she?
No,
We can't
she
see.
is not coming in. She haven't reached the participants.
Okay.
I haven't let her.
Okay.
What is happening, Veena? Oh, I think Zoom is hanging for Veena.
Okay.
Jacob?
Yes, ma'am. Ma'am is live now.
Yeah.
Beena ma'am, you are live. Hello?
Can see. Veena?
Beena ma'am, can you please talk?
Oh, she's gone again.
Again, it got cut. Ma'am, I guess she's got a very weak connection, ma'am.
Yeah, maybe. So shall I ask to carry on? Should I?
Yeah, ma'am. Can we wind up, ma'am?
Yeah. Then
All
we'll
right.
I'll tell her to wind up.
All right, ma'am. Thank you so much. Thank you. So, yeah, so that's about it. And we've got an amazing session. Thank you, everybody. Thank you, Jochandi sir, for coming in and talking to us. And also a special thanks to Anuleka ma'am for connecting us with Dr. Beena. And thank you all delegates and students for your participation. Really appreciate that. Thank you, Dr. Jijo, for your questions, and all students for your questions. And so, thanking the speaker and the moderator once again, let me sign off from Believers Church Medical College. And until we meet on Saturday with a geriatrics webinar, a special geriatrics webinar, a speaker from the United Kingdom who is with NHS as a specialist geriatrician will be talking to us about various aspects of geriatric care. So until then, take care, stay safe, and God bless. Bye. Thank you, everybody.